different. It's a difference in preference between anatomists and anatomy books that we use between last year and this year. If you put notch or fossa, I'll give you credit for it. It's just one thing that I now noted that I know I need to change. All right, we will get, let me hook my phone in. We'll get started. All right, picking up from last time. Now we're moving more distally on the tibia and fibula. That's recording. Yes, it is. All right, more distally. We have the, so we had the proximal tibiofibular joint. And so then at the distal portion, we're going to have the distal tibiofibular joint right here. And then get the term sheet here. Side leg tib fib. All right, and then the last two structures, last two structures right here on this distal portion that we got to know are the malleoli. Malleoli are these two bumps on either side of your ankle. Your medial malleolus is right here on your tibia. This is medial. Oftentimes you may hear people call it malleolus or malleolus, depending on where they went to school and which anatomists they studied under. Anatomist I studied under called it malleolus. This is lateral. And one of, we'll get to it, but you can kind of see how the medial malleolus doesn't, is more proximal or doesn't have as distal a protrusion as the lateral malleolus, which can provide anatomical reasoning as to why we might see more people have a inversion or lateral ankle sprain compared to a medial ankle sprain, because we have this much longer bony structure right here protecting us from having a eversion or twisting out towards away from your body, out from your midline ankle sprain, where you're spraining the ligaments on the medial side of your ankle versus the lateral side of your ankle. Yep. So medial is on the tibia, lateral is part of the fibula, the distal portion of the fibula. And then We also have tibial shaft here. Okay. So then when we're looking from the back side here, let's start with Tim. What are these structures right here that I've highlighted in pink? They're not a fossa, no. They are condyles. So that's the second part of it. So then what bone are they on? So they are the tibial condyles, right? So we have the, oh, hold on. We need to orient ourselves. Let me draw our compass here. So we have superior. So we're going to have medial, superior, lateral, and inferior. So we will have this condyle is the medial tibial condyle. And then we have the lateral tibial condyle. And then between them, Parker, we have right here is the what? Intercondylar eminence. And then we have, if we move just laterally, this structure right here, Grant is the what? Yep, the fibular head. All right, and then we have this structure here. Mr. Marks is the what? Interosseous membrane. And then we can also see this structure down here. Teo is the what? Yep. Lateral malleolus, which then makes this structure right here, Bree, the what? Medial malleolus. And then that also makes so then we have this joint right here. Mia is the what? Very good. Proximal. Tibiofibular. I'll spell it out for you. That's a little too big. And so that then if that's the proximal tibiofibular joint, Kayla, yep, right in here, that's going to be the distal tibiofibular joint. LAR joint. All right. So then with all these structures, what is the one structure that we went over that we cannot see on this posterior view? Mr. Mark. Yes, the tibial tuberosity. Very good. All right. Any questions on the tibia and fibula? So briefly, some biomechanic differences between these bones. You can obviously see that as we move into the ankle joint right here, we can see that the tibia is taking more of the brunt, more on the on one of the bones, bearing more weight of the foot than the fibula. Your fibula typically does not bear weight at all, and if it does, it bears very little amount of weight. But the important reason as to why we need both of those bones, one is to hold your ankle joint in place. The other reason is if we didn't have a second bone right there, you wouldn't be able to move your ankle nearly as much. And so what happens is when you dorsiflex or bring your toes towards your shin, towards your tibia, the distal tibiofibular joint will experience some stretching, and it will partially, separate, create a little bit of space between the two. And so what this presents in some patients is if they break or if they have a stress fracture of their fibula, every time the patient takes a step, you are going to place strain all along the bone. And so that's typically why, even though the fibula doesn't bear weight, we still place patients in a boot after they have a stress fracture or they break their fibula, because we don't want that bone to be moving and placing additional stress on a healing fracture. That make sense? Great. Is it mostly the muscles or the bone that is taking the strain? Oh, that's a good question. So you're definitely going to have muscles pulling on the bone when you move your ankle. I'm not exactly sure if that mechanical stress of the fibula moving during normal gait is more contributory towards pain, or if it's more muscle. Clinically speaking, That's really like a physiologic anatomist question. Clinically, in my clinical practice, doesn't matter if the muscles are placing more strain or the bone is taking more strain. If we're putting additional strain on that injury site, then that's going to contribute to more pain, worse patient outcomes, might not heal right. So clinically speaking, don't matter. But it's an interesting question. When we have so the presenter that's coming in last for ultrasound, her name is Dr. Bliven. She is a clinical professor of anatomy at AT Still, and that would be a good question for her. So I want to know. More strain. Sure. All right. Once again, any questions on tibia or fibula? All right. Moving on. So now, okay. So we're just doing bones. So now let's move on to the foot here. We will come back to that image right there with the ankle joint. So this view, this is a superior view. So we have, let's draw our compass here. So we have anterior, posterior, and then we have medial and lateral. Okay. There's our directional compass. And we have a couple of groups of bones in this picture. So all of these bones right here. Missed some. What's that tiny sliver? Boop. There we go. Much better. All of these bones are called tarsal bones. So if you recall from our wrist and hand section, the most proximal bones in our wrist were called carpal bones. These are now tarsal. Tarsals in your toes, carpals are in your hand. Carpal and tarsal, T-A-R-S-A-L. So then if these are tarsal bones, and Chloe, what are these bones? Intermediate tarsal. So think about the wrist and hand. We have the carpal bones. Then moving distally, what do we have? Next row of bones. Metatarsal bones. Same pattern. So these bones are metatarsals. And then the exact same name as in our fingers, Roz, these bones up here are going to be the what? The phalanges. So similar schematically, anatomists doing us a solid. Proximal to distal, or if you really want to argue, posterior to anterior, tarsals, metatarsals, phalanges. In the wrist and hand, we got carpals, metacarpals, phalanges. So just a little bit different. Tarsals in your toes, carpals in your hand. All right, so now another superior view. Let's orient ourselves here. Superior view. We have anterior. We have medial, posterior, and lateral. All right. So let's start with the bone that's going to be in direct contact with most of the weight of the tibia, what forms the joint between the tibia and the foot bones. This pink bone right here that I've highlighted is the talus. The talus. And then we can see just inferior to it, sticking out a little bit to the side, this bone back here. That is the calcaneus, or your heel bone. A-N-E-U-S. And then we move into more rows of bones. So we have first, starting medially and moving laterally, we have this bone right here, which is called the navicular. A-R, navicular. And then we have this more cube-shaped bone, and we call this one the cuboid. Quite cute. Cuboid. And then we have three bones right here that are cuneiform bones. And we're going to start medially here. And anatomists have once again done us a nice solid, and they have labeled them or named them by their location. So we have the medial cuneiform. We have the intermediate cuneiform, articulating with the navicular and that second metatarsal. And then we have the one that is most lateral, going to be the lateral cuneiform. All right, so then now we have our metatarsals. We have labeled them based upon their number, going medial to lateral, 1 through 5. And one unique feature of the metatarsals, we have one metatarsal that has a bit of a overhang. So if we look here, that fifth metatarsal, it doesn't exactly line up and doesn't have kind of what I'll call exclusive rights with an articulation between a tarsal bone and the metatarsal. And so we have the tuberosity of the fifth metatarsal right here. And 2, 3, just. And one problem that we can run into is that this structure, this tuberosity, we sometimes have patients that fracture or have an avulsion fracture. Bone gets pulled off with muscle tendon, an avulsion fracture of the tuberosity of the fifth metatarsal. And that fracture is called a Jones fracture. It's relatively common, so common that it has its own name. So then when good clinicians assess for ankle injury, there are some tests that we do, some palpation points, where we look for specific areas that would indicate to us that a patient would need an X-ray, because quite often in patients with ankle sprains, we have over X-rayed. So there's a couple of points that we palpate. So the first point that we palpate are medial and lateral malleoli. And we also palpate the posterior ridges of the medial and lateral malleoli, the distal 6 centimeters. We palpate the navicular bone, and then we also palpate the base of the fifth metatarsal, or the tuberosity of the fifth metatarsal. All points that, if one of them is positive or a couple of them are positive, can indicate to us that a patient may need to be seen for an X-ray, compared to someone who isn't tender in any of those points, but is tender, say, near between their medial and lateral malleoli, or between their lateral malleoli and the calcaneus, or right in this area right here, to where we have ligaments that are commonly sprained with an inversion ankle sprain. Much more common. All right. So then, last point, just like the hand, we have phalanges. So we have proximal phalanges. We'll do this. So we have proximal phalanges here. We have intermediate phalanges on toes 2 through 5. And then we have distal phalanges on the final 5, on all 5, excuse me. So proximal, intermediate, and distal. These are all GES phalanges. Okay, and these are okay, metatarsals. There we go. Any questions on bones of the foot? All right. So then let's look at an inferior view right here, for a plantar surface. So let's orient ourselves again. We have anterior, posterior, and medial, and lateral. Okay, and we're looking at this structure right here. So we can appreciate just a little bit more. First, big bone, heel bone. Kimmy is the what? Calcaneus, yes, very good. And then we can see peeking out just superior to the calcaneus is which bone? Michaela? The talus, very good. And then moving medially to laterally. This bone right here, Isabel, is the what? The navicular. And Tim, bone just lateral to the navicular in that proximal row, the cuboid. And then we have this bone right here. Parker is the what? Medial cuneiform. And then Grant, this bone just sticking out right there is what? Intermediate cuneiform. And then this bone right here, Andrew, is the what? Very good. Yeah. All right, and then we have this structure right here is the what, Teo? Yep, tuberosity of the fifth metacarpal or the base of the fifth metacarpal. And then moving medially to laterally, or excuse me here. This row of bones is called the what, Bree? Nope. Metacarpals. Or yes, metatarsals. Thank you. Tarsals. And then we have this row here. Mia is the what? A-N-G-S. And then we have these ones. Is this yellow or gold or orange? Orange, thank you. These orange ones, Kayla, are the what? Intermediate phalanges. And then these blue ones right here, just to mark, are the what? Distal phalanges. Very good. GES. All right. And so one other structure that we can see on this plantar surface that we couldn't see on the dorsal surface or the superior surface are these sesamoid bones right here. So these sesamoid bones are in the just inferior to the first metatarsal, just on that plantar surface. You may be able to feel those on yourself, just on the kind of the ball of your foot on your first toe, or we call your first toe your hallux. You feel those sesamoid bones on that plantar surface right there. So these are sesamoid bones. I spelled that wrong. All right. That's a inferior view. We got two more here. So this view, Roz, is a what view? Lateral view. So we have superior, inferior, anterior, and posterior. For our compass right here, orienting ourselves. And Kimmy. Big, big bone right here. Calcaneus, very good. And then we get this nice lateral view. This bone right here. Michaela. The talus, very good. And we get this bone right here. This is lateral. Isabel is the what? The cuboid. And this structure right here. Tim is the what? This structure right here. That structure right there on the fifth metatarsal is the what? Nope, it's on the metatarsal. It's a special structure just for the fifth metatarsal. So Jones fracture is a type of fracture. Jones fractures aren't structures on bones. This will be our last thing before I let you all go to lab. There we go. To Rusty of the 5th. All right. We will finish this one up next time, and hopefully by next class we'll finish the rest of it, and we'll have maybe 3, fingers crossed, periods for lab and review.